Okay, so your GI drugs, we're skipping chapter 56. We're going to go right into chapter 57, page 97. And again, this is a picture from your text that I liked that's on page 990. I thought it was great for you to do a review looking at what drugs, the class they fall in, and where they work. It might be a good review for you. Okay, so drugs to treat GERD, gastroesophageal reflux disease, and ulcer disease. Page 989. Let's see here. You start with your histamine 2 antagonist, H2 antagonist, H2 blockers. You'll hear it called multiple things. And your antacids. Both of these are listed in table 57.1, starting on page 991, and then on that page there. So your H2 blockers block the production of hydrochloric acid. There still have some acid. It kind of, I think of it as decreasing the acid in there. It differs from your next group that we're going to cover, your PPIs or proton pump inhibitors. Prevent that pump from pumping it out in the first place, but your H2 blockers block or decrease that acid production. Then for the short-term treatment of duodenal and gastric ulcers, hypersecretory conditions, prophylactically and when someone has stress-induced ulcers, erosive reflux, heartburn, acid indigestion. On your list here, cimetidine or Tagamet, famotidine or Pepcid, ranitidine or Zantac are the main ones. If you look over them, you will see on a, where do they have it listed? Tagamet would not be used, cimetidine, as often as it used to because it has a lot of drug-drug interactions. And children, famotidine is the only H2 antagonist approved for use in children, even though you will see some pediatric doses on the others. Famotidine is the only one actually approved. Older adults, as with any drug, have an increased chance of adverse effects. Some other things with your cimetidine, treatment of duodenal ulcers, GERD. Oh, it does say here, special note, not for children under age 16. I missed that there. The main thing on your available in oral parental forms for all of them. There is something here in your contraindications and cautions. Cautions should be used during pregnancy or lactation because of possible adverse effects on the fetus, and caution with hepatic or renal dysfunction. Another major adverse effect with the cimetidine is the development of gynecomastia. Gynecomastia is like development of small breast in a male. I said the drug-drug interactions with any H2 blocker, more so with cimetidine, is increased or possible toxicity with warfarin, beta blockers, phenytoin, which is dilantin, or tricyclic antidepressants. I just realized here also salicylate levels or aspirin. Anytime you see anything with salicylate, that is your acetylsalicylic acid or aspirin. In your critical thinking scenario, you want to look over that nursing care guide for W2 and H2 agonist, that little assessment history examination section. Also into your implementation evaluation section, look over your nursing considerations on your histamine 2 antagonists. Then we're going to go into your antacids. That begins on page 996. They also have them listed in your table. Let me get back over here. Your aluminum salts, calcium salts, magnesium, and sodium bicarb. Although sodium bicarb is listed here, sodium bicarb is any of these antacids have a risk of overuse leading to an acid rebound. Your sodium bicarb much more so than the others, but any of them overuse or extended use, acid rebound. So your antacids are used for symptomatic relief of upset stomach, hyperacidity, when you have gastritis, ulcers, esophagitis, even a hiatal hernia. Adverse effects are electrolyte imbalances, especially like with these calciums, aluminum, magnesium, whatever's in them, causing an increase in that electrolyte in the body. They all have the adverse effect of constipation. Maalox is the best of them because it's combined, it's an aluminum calcium combination, so they have less side effects. All of these are no other medication should be given at the same time as an antacid, and antacid should be taken 1 hour before or 2 hours after any other medication. You want to look over your nursing considerations. Begin for your antacids at 997, mostly over your implementation and rationale. Then we're going to go right into here on your proton pump inhibitors, often referred to as PPIs. You can remember those as your prazoles, esomeprazole, people know as your Nexium, omeprazole, which is your Prilosec, pantoprazole, or Protonix, lansoprazole, which I can't think of the brand name for that one right at this moment. So your PPIs begin on page 998. Your table is that table previously, let's see, table 57.1 on 992. Here's your pantoprazole, Protonix. It just wouldn't come to me. Okay, so the proton pump inhibitors, unlike H2 blockers, the H2 blockers block that acid or decrease the acid production. Your proton pump inhibitors block that acid from being released in the first place. The adverse effects with them are dizziness, headache, vertigo, insomnia, diarrhea, abdominal pain, nausea, vomiting, cough, stuffy nose, hoarseness, epistaxis, which is your bloody nose. Main thing is a decrease in calcium absorption. So if you have a decrease in calcium absorption, especially like in a postmenopausal female, you have an increase in bone loss, increased chance of osteopenia, osteoporosis, and fractures. Also, proton pump inhibitors always must teach your patient to swallow it whole, not to chew it or break it up or crush it. Anybody on chronic use of proton pump inhibitors is at increased risk of developing C. diff, Clostridium difficile, a horrible smelly diarrhea infection. Let me see what else you want to know. Flip it through your book. Here's your nursing considerations for your PPIs or proton pump inhibitors on page 1000. 1000? Yes, page 1000. Caution used in pregnancy or lactation. There is no safety, for those over age 18, except lansoprazole is the only proton pump inhibitor to be used in children if it's absolutely needed. Okay, so your antipeptics, prostaglandins beginning on page 1001, gastrointestinal protectant, and table 57.1 should be defined here. Way back earlier in the chapter, because they had the one table for all the drugs in here. The only GI protectant is sulcrophate, which most people may know as carafate, but sulcrophate covers duodenal ulcers, prevents pepsin in the peptic ulcer, and it allows that ulcer to heal. It is, as said, the only GI protectant. It does cross the fetus, of the barrier into the fetus and over to the breast milk, so use it with extreme caution in pregnancy or lactation. Major adverse effect with sulcrophate is constipation. It's one of those drugs that you'll use 4 times a day before meals and at bedtime, but it can be very constipating. Do not give in renal failure. Other side effects: nausea, vomiting, diarrhea. I've never seen that. Mostly constipation. Vertigo, headache. I've seen a lot of headache with it. Rash, dizziness, sleepiness. I've not seen that. I have seen the back pain. It can also block or decrease the drug levels of fluoroquinolones. It is excreted in the feces. If you're going to give it with an antacid or antibiotic, it needs to be 2 hours away from the dose of your carafate or sulcrophate, because it just coats everything. Do they have a... Yes, it does. It does have a nursing consideration on 1002 on your sulcrophate. Now your prostaglandin, which on table 57.1 on page 992, the only one you have is your misoprostol. It's your only prostaglandin. If you remember from earlier this semester, your prostaglandins coat your stomach and your kidney. They are protective. That's where your NSAIDs, non-steroidal anti-inflammatories, block prostaglandin production to decrease inflammation. So your prostaglandin or misoprostol can be used to prevent the ulcers coming from NSAID use. Hopefully that makes sense. It also inhibits that gastric acid production, increases bicarbonate, which is protective and prevents that ulcer. Absolutely cannot be used in pregnancy, so this is the one that you're going to do a pregnancy test to assure they are not pregnant. They must use a secondary form of protection if they're on misoprostol, because it causes severe, it can cause a miscarriage. Also, caution if they have hepatic or renal disorders. It may, I said, it can cause a miscarriage. They may also have spotting or menstrual dysfunctions or variations if they're on this. Major adverse effects, others are nausea, vomiting, diarrhea, abdominal cramping. Let me see what else in your text. Prostaglandin, there is nursing considerations on page 1003. You want to read that. I told you about the pregnancy test. It even says here to do it within 2 weeks of beginning treatment and starting it after the menstrual period, so because of the miscarriages. Okay, so we're going to keep moving into our pancreatic enzymes, which is on page 1005, actually 1004. Your table 57.2 is on 1005. Only want you to worry about that first one, pancreolipase. Pancreolipase, pancreatic enzyme. This is for that person with cystic fibrosis or pancreatic dysfunction. They don't produce these pancreatic enzymes, so they cannot digest or absorb certain foods, so they take the pancreatic enzymes with every meal. Not 30 minutes prior, not 30 minutes after, with every meal. It comes in capsules or delayed release capsule, powder, or a tablet. They are not to crush or chew the medication unless it's already in the powder form. take it with their meals and with the snacks. Adverse effects are GI irritation, nausea, and abdominal cramps. As you can see here on your prototype in 1005, it replaces the pancreatic enzymes to aid in digestion and absorption of fats, proteins, and carbohydrates. Very necessary. You might want to look over those nursing considerations on that same page. Over in the second page, 1006, I had something circled. Administer with your meals, which I did cover, so look over that. Now we're going to go into chapter 58. This is your drugs that affect your gastric motility, so whether it be for constipation or diarrhea. Again, I pulled the picture from the text because I thought it was very good in looking over to help you review, that you understand how each of these drugs work. So your laxatives, there's several different types. Your chemical stimulants, which irritate the bowel to get it to go. Biscodol and Senna are common ones. Your chemical stimulants start on page 1011. And you have your table of all your laxatives, table 58.1 on 1012. You will see there the first chemical stimulants, Biscodol and Senna is what you want you to focus on. Your Biscodol before surgery or diagnostic tests such as a barium enemas to empty everything out. Your Senna is for short-term treatment of constipation. These, because they're a chemical stimulant, they are not absorbed, but they may actually cause some CNS effects due to that nerve stimulation. Those effects are dizziness, headache, and weakness. Do not give any medications with 30 minutes of giving a chemical stimulant. Let's see here if we have. No. Okay, so then your next is your bulk stimulants. On your list of bulk stimulants, I wrote here which ones for you to focus on. They're in your table, your lactulose and your polyethylene glycol electrolyte solution. I wrote Go Lightly because that's what I know it as. What you'll see it mostly listed as is Go Lightly, but polyethylene glycol electrolyte solution. Electrolyte solution should be your cue as to what it is. It's to evacuate the bowel prior to a procedure, GI, colonoscopy. It's to empty everything out. Your lactulose has a couple of uses. Short-term use of constipation. Alternative choice for patients with cardiovascular disorders. It's safe to give lactulose. Lactulose is also given for, what do you call it? Hepatic encephalopathy, when the liver enzyme, they're in liver failure, cirrhosis, their ammonia levels get increased and it causes encephalopathy, inflammation in the brain. So they're given lactulose to pull the ammonia level down. And the lactulose also contains no salt. That is why it's a drug of choice for cardiac patients. It is rapid acting. Both of these are rapid acting and very aggressive. It evacuates the gut. Your third type, your lubricants, and think of it exactly that way. Easy passage, it lubricates. It's docusate and mineral oil. So think of mineral oil as coating, making it where they don't have to strain. Unfortunately, it can lead to leaking, staining, diarrhea, and it does have central nervous system effects. Interferes with absorption, main thing, absorption of fat-soluble vitamins. It is the drug of choice if there is an impaction or if you need a person not to have to strain. But mostly a person with impaction, you're going to give this to lubricate to get them to go. In your text, where is it? there is here's your nursing considerations. I'm trying to find it. Page 1018, nursing considerations for gastrointestinal stimulants. You might want to look over that. Okay. Metoclopramide. Got myself confused there. You look over your nursing considerations for patients receiving laxatives on 1016, and then your stimulants I mentioned 1018. The only gastrointestinal stimulant I want you to be aware of is metoclopramide, often referred to as Reglan. Metoclopramide is used for gastroparesis, which you'd be more familiar with as you study diabetes. Some diabetics can have gastroparesis. The stomach doesn't pump and squeeze as well as it used to. So the food sits in there. You give metoclopramide to get things to move through faster. Short-term treatment of GERD, gastroesophageal reflux. It's not for long-term use. Of course, if there's a GI obstruction, of course it'd be contraindicated because it stimulates things to go through faster. It decreases the absorption of digoxin. It can be used for nausea and vomiting and is mentioned in chapter 59. Okay, so now we're going to get into the antidiarrheals, starting on the bottom of page 1019. Also listed on the next page, 1020 in table 58.3, bismuth subsalicylate or Pepto-Bismol, and you notice the salicylate in the name, so know that it should not be given in anybody with an aspirin allergy. Your other one, loperamide or Imodium. Those are the two I want you to focus on. The block stimulation of the GI tract, inhibit or reduce activity of the GI tract, caution of pregnancy lactation, history of GI obstruction. Caution of diarrhea due to food poisoning because you want that bacteria from the food to get out of the system. You don't want to slow it down. What else do you need to know? Your bismuth subsalicylate is absorbed in the GI tract. It does cross over the placenta and enters the breast milk. Of course, that is an aspirin, so you're going to use extreme caution there. What else? I'm looking over your critical thinking scenario. You might want to read over your critical thinking scenario there on page 1021. Loperamide is mentioned in your prototype summary on 1022. You see your adverse effects: abdominal pain, distension or discomfort, dry mouth, nausea, constipation, dizziness, tiredness, and drowsiness. It's for relief of acute, nonspecific diarrhea and chronic diarrhea. So somebody with irritable bowels, somebody with an ileostomy that has these liquid stools, so loperamide itches to treat that acute loose stools diarrhea. Okay, we're going to keep moving. This is we're going to go into chapter 59. Again, this picture is from your text. It shows the place that each of the drugs and classes that we are going to cover were good for your review and checking yourself. This is good for the adverse effects. And again, included that from your text because it was a great picture of the adverse effects of these. That picture's on page 1032 in your text. So you want to look over those adverse effects. Antiemetics, page 1030. No. All right. Starts on page 1027. And then table 59.1 starts on page 1028. Starting with your Phenothiazines, your first class, I just want you to focus on the prochlorperazine, and which is the class of the phenothiazine. Notice here central acting changing response of the chemoreceptor. The chemoreceptor trigger zone that is mentioned in your little picture figure 59.2 on page 1032. Your central nervous system, that drowsiness, dizziness, weakness, tremor, headache, is because that CTZ, chemoreceptor trigger zone, that's where it's working while you have the central nervous system effects. Another is phenothiazines can be used also for severe nausea and vomiting, but your prochlorperazine, I'm having trouble with that, can be used for intractable hiccups. You can have pink urine, some teaching for your patients, pink urine, photosensitivity, menstrual disorders, galactorrhea, which is leaking of milk from the breast, and gynecomastia, which is the breast development. There are drug-drug interactions with central nervous system depressants because it's working in that same part of the brain, and alcohol because it also is a central nervous system depressant. And you see here your promethazine, which is your Phenergan. So your promethazine has that anticholinergic effect. It's also a, what do you call it? First generation antihistamine, so it has that extreme anticholinergic effect. It blocks the H2, giving it an antiemetic effect, but it's contraindicated because the anticholinergic effects, the promethazine is contraindicated in BPH, or benign prostatic hypertrophy, and narrow angle glaucoma. It can be used as an antiemetic for motion sickness given 30 minutes prior to the activity for the motion. Your 5-HT3 receptor blockers skip your non-promethazine, that's your methylcopramide or Reglan, which we already talked about, because it can be used for nausea and vomiting. Your 5-HT receptor blockers, just want you to focus on your Donastron, which everybody knows as Zofran, severe nausea and vomiting associated with chemotherapy, but it's also been used postoperatively and for other times of nausea. It can be given in an injection, IV, IM, pill, or even a sublingual to dissolve for rapid release for that really nauseated person. Adverse effects are headache, dizziness, muscle aches. Because it's working in that chemoreceptor trigger zone, you have the central nervous system symptoms with it. Your miscellaneous agents, your dronabinol or marinol, which is controlled substance used for nausea, vomiting, cancer patients. The marinol, or dronabinol, they took out the they don't get high off of it when it's what's called medical marijuana. Trimethylbenzamide or Tigan doesn't give as much sedation or central nervous system depression, so that might be preferred in certain situations. Of course, your nursing, look back here, look over your critical thinking scenario that begins on page 1030. Told you about intractable hiccups. I'm just glancing through here. Look over your nursing considerations for antiemetics on page 1035. And I think that's really it. And of course, I put your silly slide here. It's because this is the end of my lectures for pharmacology, and I hope this lecture was helpful.